So we'll start then, right? So good evening, everyone. On behalf of the Association of Healthcare Providers Network, we are more than 15,000 hospitals. It gives me great pleasure to welcome all of you to today's session. This is the third webinar in the ongoing series. The feedback from the earlier two sessions have been excellent, and that has encouraged us all to raise the bar each time. As you can see from today's panel, we are committed to bringing the best experts from all over the country. All our speakers today are nationally and internationally known: Dr. Chitranjan, Dr. Prabhu, and Dr. Das. And we personally also, we go back a long way. They're both nationally and internationally known in their respective fields. And it is truly a privilege for us to have them with us today. Thank you so much for joining us. Also wanted to thank Farmed for sponsoring this webinar, and trying to continue to support our efforts to make these knowledge sessions meaningful and impactful, mainly for our junior colleagues and for the students. As in the previous three webinars, thankful to Dr. Santosh for taking on the role of moderator. He's a senior consultant at the Bangalore Baptist Hospital and my colleague for many years. This webinar is a little different from the earlier webinars. Earlier, we had the three speakers followed by questions and answers. Here, the three experts will speak for about 10 minutes. This will be followed by a debate and interaction among the panelists, which Santosh will moderate, and then we will have some time with the open the floor for questions and answers. Request all the speakers to keep time so that we can have ample time for interaction with the audience. And usually that is a very interesting part of it, and Santosh handles it very well. So thank you once again for joining us, and we look forward to a very enriching and engaging webinar after the traditional lamp lighting. Over to you, Saurabh.
शुभं कुरुत्वं कल्याणं आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणं आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम् दीपनमोऽस्तुते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश्च मतिं स्वच्छामि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् यस्य तिष्ठेत् गृहे दीपः तस्य नास्ति दरिद्रता
Over to you, Santosh.
कुरुत्वं कल्याणं आरोग्यं धनसम्पदः.
Good evening all. So I welcome you all as for this webinar on foot and ankle tendinopathies. So we'll be advancing to the more advanced treatment here. So regarding the first speaker, now since this foot and ankle tendinopathy is like part of our regular clinical practice, so much so that you'll have at least 10 to 20% of your OPD at any given time with some of the other foot and ankle tendinopathies. And Dr. Samuel sir will be starting with this today's webinar with overview of tendinopathy and the medical management involved. Over to you, sir, Sam sir.
Thank you, Dr. Santosh. And let me put my, sorry. Okay. Am I seen and audible?
Yes, yes, very much.
All right. So thank you. So thank you for the opportunity, and it's a great honor for me to be part of this very interesting program today. And I'll start with the first question: what is tendinopathy? And sorry, tendinopathy is a painful dysfunction in a tendon, and it is defined as an altered or abnormal healing response which results in haphazard proliferation of tenocytes and intercellular substances, which cause thickening, disruption of the collagen fibers, and it results in the increase in the non-collagen matrix. There is this thing that tendinopathy is non-inflammatory. I would like to say that inflammation is minimal in the sense that inflammatory cells are not that obvious. It is characterized by pain, therefore there is some inflammation. It causes reduction in function and reduced exercise tolerance. Healthy tendons, in contrast, are white in color, have a fibroelastic structure, and the extracellular network, which consists of the tenoblasts and the tenocytes, are the majority, 90 to 95% of the cellular elements of the tendons. This changes in tendinopathy, where the cells reduce. As you know that the microstructure of the tendon is made of fascicles and fibers, and eventually you come to the microstructure, which is made of tropocollagen, which is arranged in a longitudinal fashion, which gives strength and elasticity to the tendon. Now, when we talk about tendinopathy, there is a continuum, as they say, tendon continuum of pathology, and there are three stages to it. First is the reactive tendinopathy, where there is actually more pain than in the acute phase. There is inflammation. And then when this is unchecked or untreated properly, it gets to the second stage, which is the disrepair stage. The tendon swells up and there is internal damage going on. And if this is not addressed properly, then it goes to the third phase, where there is degeneration, there is fraying of tendons, and it may eventually lead to even rupture of the tendon. So this is the tendon continuum from the early stage to the final stage of degenerative tendinopathy. Now, there's a lot of talk about what is the etiogenesis of tendinopathy, and we'll come to that. This is just a cartoon which tells you that there is cell apoptosis, that is cell death, and there is molecular level inflammation. Even though grossly we may not find that, there is dysregulation of the immune system, and there is the matrix metalloproteins are secreted, and there's a lot of cytokines and chemokines come into play. Eventually, that leads to degeneration, and it inevitably goes to the third stage if it is not treated properly. So what are the risk factors? There are intrinsic and extrinsic factors. The intrinsic ones are age related, and as you can imagine, as people grow older, their response to micro trauma or anything like that, and when tendinopathy is considered, there is what is called an overuse that triggers this whole cascade of events. And so age is definitely a big role to play in this. In the anatomy, if the muscles are used improperly, there is imbalance, and there is stiffness, malalignment of the limb for whatever reason. This can predispose to tendinopathy. Systemically, if a person is suffering from collagen vascular disease, diabetes, gout, hypertension, and many other inflammatory conditions, that also predisposes. Extrinsic factors, long corticosteroid use, improper activity, as with athletes who don't do the activity properly. So this can lead to overload. For all of us general orthopedists, at least, musculoskeletal conditions such as ankle sprain, Achilles tendinopathy, and plantar fasciitis are commonly diagnosed very easily. But there are certain other tendinopathies which may not be so obvious. And this includes posterior tibial and peroneal tendinopathies, tibialis anterior tendinopathies, and rarely flexor hallucis longus tendinopathies. These all present in a clinical setting, which may not be very obvious to us when we see the patient in the outdoor setting. And the posterior tibial tendon is a tendinopathy that is more often seen next to the tendo-Achilles problems. As you know, the posterior tibial tendon is the main dynamic stabilizer of the ankle in the medial side, and it strengthens and supports a medial longitudinal arch. Patients who have a posterior tethering of the tendon due to any reason, inflammatory, can lead to tendinopathy. And it presents with medial ankle pain, and you can see the planovalgus deformity or flat foot, and what is called a positive too many toes sign. That's an American term which may not be very familiar to all of us, but it's a very simple thing. And I will show you a picture of what it is. Tibialis antitendinopathy presents as anterior ankle and midfoot pain. So you see an elderly person coming with the anterior ankle or midfoot pain, think of tibialis anterior tendinopathy. And how do you diagnose this? You have a positive tibialis anterior passive stretch test, or actively resist the action of the tibialis anterior, and that produces pain. So there is both the stretch test and the active test against resistance. And this picture is very familiar to you, but just to show that the tibialis posterior tendon and muscle is deepmost. It is closest to the posterior aspect of the tibia, and it is more easily palpable when it comes to the attachment to the tuberosity of the navicular bone, and that's where you often elicit tenderness. The peroneal tendons, again, they are covered by a tendon sheath, so you can have a inflammation of the tendon sheath, which can then later on lead to tendinopathy as well. We start with history and physical examination. Any new level of activity which has been taken up by the patient in the recent few weeks would be the triggering factor for causing tendinopathy. So there is localized pain, and it is related to activity and relieved by rest. There may be swelling, and there may be aggravating and relieving factors. Commonly, patients report starting new physical activity. This is the usual history, and this may lead to overuse injury. Patients may experience pain over the involved tendon, which can progress to even pain at rest. From pain only during activity, it can also, at the worst case, be also pain at rest. And the physical examination should be always looking at both the feet and noting any asymmetry between them. Findings will include, as we were saying, swelling and tenderness over the involved tendon, and pain when activating the tendon. Passive range of movement may be restricted. There may be strength deficits which can be assessed. When weight bearing, we always examine the foot and the ankle weight bearing. We look for the arch type, whether there is any flat foot, whether it's pronation, misalignment of any sort. That will give us a lead to what it might be. Come to imaging. Generally speaking, in the outpatient setting, imaging may not be always necessary unless the problem is not easy to diagnose. For chronic tendinopathy, that means if pain and problem is lasting more than 6 weeks, X-rays would be the initial imaging study. If that does not contribute, then we go to further imaging like ultrasonography. And the good thing about ultrasonography is that you can do dynamically. And so you can look for abnormal motion, subluxation of the bones, and things like that. So ultrasound is used a lot in diagnosis of the various forms of tendinopathy. And of course, MRI can give us insights into the level of involvement and the soft tissue features can be very completely made out in the MRI when we do it as required. Treatment, short-term use of paracetamol, because there is this emphasis that it is not inflammation that is primarily driving this problem. It is always advised that we don't rely on non-steroidals or paracetamol, but for the short term to relieve the patient's acute symptoms, it can be given. However, if long-term NSAIDs are given, they can alter tendon architecture, skeletal muscle, extracellular matrix remodeling. All this can be interfered and recovery can be prolonged. So long-term NSAIDs should be avoided. Pain with ambulation can be treated with short-term immobilization, maybe in a boot or plaster cast. Rehabilitation, as my colleagues will take you through, eccentric exercises are more to be included in the program. One thing that has been said recently is the use of nitroglycerin patches for pain, but this is not the normal dose as the use for cardiac events. Cardiac events, you use 10 milligram, 5 milligram. This one is in 0.3, 0.2 milligrams of nitroglycerin patches are used in the sports injury setting. So quickly to diagnose, to put it all together, posterior tibial tendinopathy, pain around the posterior middle ankle, physical examination, pes plano valgus, positive too many toes sign, I'll come to that, pain and inability to perform single limb heel raise, and treatment would be include activity modification, orthotics as required, which my colleagues will take you through. And for peroneal tendinopathy, pain over the peroneal tendon, hindfoot varus can predispose to injury to the peroneal tendons, and passive stretch in inversion and dorsiflexion will be painful. Pain and weakness on active resisted eversion. And again, activity modification will be the starting for treatment. Tibial is anterior tendinopathy, pain over the anterior ankle and the midfoot medially. Pain on resisted dorsiflexion, and positive tibialis anterior passive stretch. Now, the big question is corticosteroid injection safe? Should it be used? There may be many of us who use it, and we all know that there can be complications because a lot of our patients are diabetic, and we have the great fear that when we inject, it can induce a tendon rupture. So corticosteroid injection has been used widely, one of the most commonly used interventions in the outpatient in orthopedics. And for the short term, it has been very effective, relieves pain and reduces inflammation, swelling. But the question is, does it weaken the tendon, and is there a likelihood of rupture? And it is advised that we don't do repeated injections. One-time injection is better. Interestingly, there have been studies which showed that tendon rupture is not all that common. A 6-year retrospective study of 109 corticosteroid injections was reported to have only one tendon rupture. A systemic review of a random control trial with many participants also showed only one tendon rupture. So if it is done properly, it is fairly safe, I think. I use it a lot in my practice. Newer therapies, prolotherapy, platelet-rich plasma injections, which many of us do use these days. Extracorporeal shock wave therapy. The energy is much less than what they use for breaking ureteric stones, but it is used by some physiotherapists, and it seems to be also useful. Dry needling, needle tenotomy sometimes required, and all these treatments must often be accompanied by rehabilitation. Prolotherapy is something that is new, and well, it is not new. It has been there for 50 years now, but I don't think it is commonly used by most of us. But it does hold promise in some situations which does not respond to the normal therapies that we have. There is a classification for all these things. Posterior tibial tendinopathy, I will pass over. I think we are running out of time. So too many toes sign. What it means is when you look at the foot from behind, because it is pronated, there is little valgus, and you see, as in this picture, there are 3 toes which are visible. Normally, you should have only the little toe and the 4th toe, half of it. So 1.5 toes is the normal. And when you see more than 1.5 toes, that is what is called the too many toes sign. It is simply a pronated foot. Peroneal tendinopathy, ankle inversion injuries, the peroneal tendons can be injured, and perhaps on one of the lateral ligaments can be sprained. Of the 2 peroneal tendons, the brevis is more typically injured. I think we will pass, but here people tend to use corticosteroid injections with greater effect, and I've also used this treatment, and it is I found it safe and effective, and you can give it under ultrasound guidance. Peroneal tendinopathies respond to non-operative treatment quite well, and some activity modification, bracing, and footwear changes can help in the long term. So this is just a picture where we show that palpating the peronei behind the lateral malleolus would cause tenderness when that tendon is inflamed. Now we come to Achilles tendinopathy, which is very commonly encountered in the orthopedic setting. And it is an overuse injury and a combination of pathological changes affecting the Achilles tendon, usually due to overuse and excessive chronic stress over the tendon. Both in athletes and non-athletes, we see that a lot also in the middle-aged population. And sometimes it is associated with a tear, partial tear of the Achilles tendon. When you examine, you find a lack of flexibility. That is, there is stiffness in the Achilles tendon, and the range of dorsiflexion can be limited. They found that there is a problem with the gene, this COL5A1 gene, which is the normal one. But these people who tend to have bilateral Achilles tendon problems and chronic, and may even have family history, they found that this gene shows a variant, and this may be related to the reason why these people are prone to this problem. When we talk about Achilles tendinopathy, it can be either insertional, that is very close to the bone, or in the upper portion. And insertional form is where you have the pathology within 2 centimeters of the insertion. Mid portion is between 2 and 7 centimeters, you have a thickening. Predisposing factors, decreased arterial blood flow. As you know, the distal part of the leg, particularly the tendoachilles, arterial blood flow is not very good. So there is local hypoxia, decreased metabolic activity, so less repair, poor nutrition, persistent inflammation leads to chronic tendon overuse and degeneration.
Sir, will little hurry up, sir, because we are exceeding the
Sorry,
time.
I didn't hear that. I'm running out of time, is that?
Yes, sir. Yes, sir.
Sorry, I will just rush through and I'll finish with this.
Important slide, sir.
Okay, risk factors, obesity, high blood pressure, diabetes. So there is a lot of this medical issues which can predispose. Old age again, and morning pain. When they wake up with pain and stiffness, and that becomes better as the day progresses. I'll just say about the differential diagnosis is important, because we tend to think that most of the posterior heel pain is tendoachilles tendinopathy, but you can have many other things like Haglund deformity. Haglund deformity, I put this picture just to show that, you know, in this picture, you have this bony projection from the calcaneus, which projects backwards into the tendoachilles and can cause bursitis there, and it can fray the tendon and cause problems. So there is this big thing about the posterior ankle impingement, or the os trigonum, which is the posterior part of the talus, in fact. You may encounter a problem with os trigonum syndrome, as it is called, posterior ankle impingement. Let me just pass over that. So this is the os trigonum, and that can impinge on the flexor hallucis longus tendon also and cause problems. So there is always a soft tissue component to the bone. So Steeter's process is where the bone is single. Ostrigonum is where the ossific center persists, and therefore it is a separate segment of the posterior part of the talus. Let me pass on. So the treatment is reduce physical stress, give time for healing, heel raise, physical therapy, concentric exercise. In contrast to the others, for this condition, concentric strengthening exercise, I think Dr. Das will
Das
take
sir
us
will
through
cover it,
that.
sir. Yes, sir.
So I will leave that. So
Yes, sir.
corticosteroid injections again are useful, and
Ram sir is covering
Professor
all.
Ramprabhu will cover surgery. So I'll leave it at that. I think I will stop here. Thank you very much
Okay,
for hearing me.
Yes,
Okay.
sir. Yes, sir. Thank you, sir. Thanks a lot, sir. Next, sir. So can you stop sharing your screen, sir? Yeah, thank you, sir. So next, thanks a lot, sir. We'll now move on to the next speaker, Dr. Das, sir, who is a renowned orthopedic surgeon and practices in Cuttack. So he's been more into pelvic surgery, daycare, THRs and all. So today he'll be giving his vast experience and insights into the rehabilitation of the foot and ankle tendinopathy, sir. Over to you, sir. Thank you, sir.
Thank you, Dr. Alex Thomas, for your kind invitation to share my experience on rehabilitation in foot and ankle tendinopathy. I just wanted to share with you one of the cases that came to me last week. This lady is about 65 and she comes and says that she is not able to walk faster like before, and I find that she has got pes planus deformity. And when I looked at her prescriptions, I found that she had been seeing us in the OPD for last 8 to 10 months, and she was given simple NSAIDs for her treatment, and gradually she stopped. She failed to propel herself during the walking process. And if you look at it critically, you'll find that she has lost the arch of the feet on both sides, and when you ask her to raise her heel individually, she is not able to do that, and when she's trying to do with both the legs, she forms a mild arch, which means that there is a flexibility in the arch. Her story is, as I mentioned to you, she presented with pain and swelling on the inner ankle and treated with NSAIDs. As Dr. Samuel Chittaranjan just mentioned to us, that this is often missed in the OPD. So every ankle pain that comes to OPD needs a proper evaluation, and you should rule out tibialis posterior tendinopathy. Subsequent symptoms were treated with NSAIDs, and she was referred for my opinion later on. I just did the X-ray, weight bearing, AP view, and lateral view. And if you look at the lateral view, this is the normal lateral view of the ankle, and you find the calcaneo angle, inclination angle is about 20 to 25 degree. In her case, the angle has disappeared, it's hardly 1 to 2 degrees. So the arch has dropped. So what actually happened, the tibialis tendon, posterior tendon, suffered from microtrauma. It was missed in the first visit, and subsequently people carried on from the first prescription, and she developed a neglected posterior tibial tendinopathy, probably in a later stage, in the stage 2. So this is what happens when somebody presents with pain on the inner side of the ankle joint, where the tibialis posterior supports the arch and gets neglected. It starts paining, and if you don't strengthen it, it slowly disappears and it becomes functionless, and the arch drops. And when the arch drops, you simply go into a later stage of tendinopathy and your treatment modality change. But if you spot it in the beginning, give a arch support, like a medial arch support, and put this tendon through a rehabilitation, you'll avoid this condition and prevent the tendinopathy. So this is the important message is you should catch it before it starts damaging. There are common tendinopathies. I will be talking about posterior tibial tendinopathy, Achilles tendinopathy, and peroneal tendinopathy. and the role of rehabilitation is a major player in the management, and the rehab application depends on the age of the patient, type of tendinopathy and stage of tendinopathy, because every stage of tendinopathy cannot be helped by rehabilitation. The goal is to prevent further progression of tendinopathy. If you find the tendinopathy in stage 2, you should stop it there. You don't allow it to go into stage 3. If you find it in stage 1, again, you treat it at the earliest so that the patient recovers faster. Ultimately, you aim to restore the tendon strength and mobility. First, identify the type of tendinopathy, whether it's a peroneal tendinopathy, whether it's a tibialis posterior tendinopathy, whether it's a tendoachilles tendinopathy, and what stage it is. First thing is to control the pain, which is basically, there is a mnemonics called rise, rest, ice application, elevation, and compression. So you control pain, elevate the part which is painful, and give compression and ice. And once the pain is controlled, you try to stabilize the tendon by giving orthotics. Once the pain is reduced, load the tendon progressively through physiotherapy. The tendons remodel under load. So once you start loading, you start with eccentric loading, then go to centric loading, and finally the tendon, it may take a very long time, and finally the tendon recovers to its near normal situation. So use orthotics to augment your recovery process as and when necessary. So we'll go to the first posterior tibial tendinopathy. I just wanted to share, these are the clinical stages. First is the mild symptoms, when there is pain, swelling, arch is all right, and the patient is able to raise the heel. And moderate swelling, weakness, failure to raise the heel, and the flexible arch collapse, it goes to stage 2. So you find in this case, the patient is able to raise her heel, and there is still the arch is intact on the medial side, and this is in stage 1. Same patient on the other side, you find the arch has dropped, still the patient is not able to lift the heel. And when you find this is in stage 2, you find the tibialis posterior tendons on both the sides are swollen, and they are literally painful at that point. So coming to the next stage, the arch becomes rigid and the heel and toe go into eversion. You see the too many toes sign which Dr. Samuel Chittaranjan described, and patient develops subtalar arthritis. This is not amenable to rehabilitation. Patient will undergo surgery. Stage 4, to all the factors in stage 3, there is arthritis in the ankle joint, more in the lateral compartment, and again this cannot be tackled by rehabilitation. So rehabilitation can tackle only stage 1 and stage 2 of posterior tibial tendinopathy. This is a stage 3. You can see the fixed flat arch, and in inverted toes you will not be able to tackle with rehabilitation methods. So stage 1, as I mentioned, rest, ice, compression, elevation plus isometric exercises from the day 1. Then progressive mechanical loading gradually increases the tendon strength and muscle to handle stress, followed by eccentric exercise, and then a normal loading activities to support. So I'll show you one video for eccentric exercises. This applies to tibialis posterior, and you just do the reverse for the peronei. I'll just show you the video. Please try to listen. It's being described here.
Das sir, can you describe it? We are not able to hear the
Yeah,
audio.
okay. What he's doing actually, he's passively lifting the ankle to the position, he's mimicking the action of posterior tibial tendon and holding it in that position while the TheraBand is trying to pull it down. So basically, the posterior tibial tendon is under stress in eccentric position, and gradually the patient leaves the ankle to come back to eversion and plantar flexion. So this is the way you can start loading, like we do the muscle strengthening exercises, eliminating the gravity. The next stage you put little resistance. This is a little resistance put in the eccentric mode for posterior tibial tendon. You do the reverse for peroneal tendons. You do it exactly the reverse for the peroneal tendons. So this is one way of doing the eccentric loading of posterior tibial tendon. and you often find the arch is lost, so you try to give a arch supporting footwear, so the patient maintains the arch gets relieved. Next, coming to tibialis tendoachilles tendinopathy, as Dr. Samuel Chitranjan mentioned, it has got insertional tendinopathy, which is like this. Part of the insertion also gets calcified. Then mid-portion tendinopathy, which is about 50% of the cases, you find a bulge nodule in the mid-portion of the tendoachilles, about 2 to 7 centimeters above the insertion. Then sometimes you find at the musculotendinous junction tendinopathy. This is the insertional and mid-portion tendinopathy. The stage 1 management is again same, rest, activities limited, like swimming is allowed but no high resistance exercises. Is basically to do isometric exercises, then go to isotonic exercises, and patient should stand with the feet in the shoulder width apart against a wall and start raising both the heels and hold it for a few seconds and gradually drop. So this is the way you can load, and the factor which controls you is the pain. If the patient is having pain, in a pain score say 0 to 10, if he is having 3 plus, you should stop. And if the patient after exercises is having pain after 24 hours, then you should also reduce and put ice. This pain is the only controlling factor. There is no other way you can know whether the patient is overdoing or underdoing. And this is to be repeated to strengthen the muscle. This is how you do it. And keep the wall against your back so that you support the tendoachilles. Eccentric loading and strength, perform heel raises on the flat surface and without the back support. Try to raise both your heels, and gradually you start dropping the normal heel back to the ground and then the affected heel. Slowly you try to reduce it, and this is the way you can gradually start loading the tendoachilles for strengthening it. So this is a gradual progression. It may take time, but the ultimate thing comes when you start doing it on the steps at your home. You raise both your heels and slowly drop to the level of the step, then go beyond the level of the step and try to raise your heels. This is the way you can strengthen your tendoachilles. Energy storage and return to function. Because we are involved in doing a lot of activities, it is important that you should start doing hopping on the spot on 2 legs, then go to the injured leg. Dynamic movements, hopping forward, backward, sideways. Then sports people should focus on control larynx without doing much dorsiflexion, especially on the insertional type, because it induces compression injury. Again, as I mentioned, progress is controlled by the pain factor. And the function, if it is functioning satisfactorily and you have mild pain, you may have to ignore the pain. This is an insertional tendinopathy. Patient refused with a Haglund deformity. Patient refused to undergo surgery. So for such patient, you can see big echogenic tendinopathy at the insertion of the tendoachilles, and the big Haglund deformity is likely to rupture, but she refused surgery. So in that case, you avoid dorsiflexion, use shoe heel raise. Manual stretching into dorsiflexion is not advised. Tendoachilles mobilization is very effective. You can give ultrasonic therapy to relieve pain and also to mobilize the tendon, but we don't recommend steroids in these cases. And the physical therapy, this is a passive stretching exercises for tendoachilles, and this is manual needling with the thumbs on both the sides of the tendoachilles, trying to mobilize the tendon. And you can use TheraBand, give the patient TheraBand to strengthen the tendoachilles at home. And if the patient has a lot of pain, then you can give ultrasonic therapy to the painful site, or extracorporeal shockwave therapy, which is also very effective. So these are the later on you can start strengthening your gastro, strengthening your soleus by stretching, and calf foam rolling also is very effective as a physiotherapy method for tendoachilles. Coming to peroneal tendinopathy, as Dr. Samuel Chitranjan mentioned, is overuse, and it's often caused by activities that strain the peroneal tendons, also the lateral collat ligament of the ankle. It can result from an acute injury, and it responds to same treatment in the conservative way. It takes about 3 to 6 months time to recover. Sometimes it takes longer. I'll share with you a case. The symptoms: pain along the lateral ankle and swelling, redness and warmth around the tendon. This is during the COVID time. One of my relatives was in Bangalore and he was playing football, and he sent this picture and I suspected whether it's a lateral collateral ligament injury or a peroneal. I was suspecting it's a peroneal tendon injury, and I asked him, where is the tenderness? Somebody pointed me to the place where the peroneus longus is getting into the plantar aspect. So I asked him to go for a MRI, which confirmed the peroneal tendon injury. And then there was a thickening, a nodule-like thickening in the tendon, and there was ankle was unstable, and he was treated in the same way. Then he was given a pneumatic boot, which where he could also apply ice, and he was going for a dog walk every day, and that really aggravated his symptoms. So I stopped him from doing that. I monitored him on the video because it was COVID time. He could not go to anybody. Then he started performing gentle stretches, and the physiotherapist gradually helped him to improve the tendon strength. And he was wearing supportive footwear to reduce his symptoms. This is the swelling. The patient has swelling for a considerable time because they often have lateral collateral ligament injury. So this is even after 3 months he had this swelling. Now he's back to football again. But I just wanted to show you, he complained of pain around the heel. He was not very sure on the medial aspect on the heel. But I found out later on that he also had concomitant FHL and FDL injury. You see the video, his toes started locking when he was mobilized and he was back to his feet. He found that the toes started locking and unlocking, and the pain was under the flexor retinaculum. So this was a combined injury of peronei with the FDL and FHL. So this is very peculiar, and I have not seen such case earlier. So I thought I should share with you. And recently I am seeing a patient who has both peroneal and posterior tibial tendinitis. She is in her 60s, and you can see this is the peroneal tendinitis, and she has lost the arch of the foot, and on both the sides. This case we are going to discuss in the panel. And so the peroneal tendinopathy, isolated peroneal tendinopathy, usual response to rehabilitation in 3 to 4 months time. Progressive loading of the tendons through eccentric loads builds up the muscle strength. Orthotics and molded footwear helps. Orthotics are tremendously helpful, and we have got sensors in the foot, sensors which help us to make footwear specific for the patients. So take home message is early diagnosis and early intervention makes rehabilitation most effective. Tendon injuries heal well if treated on protocol. Early protection to reduce the load, offending load, and gradually put therapeutic load. Tendons remodel by increasing the stress. Progressive loading is controlled by indicative pain score, which I just mentioned. Remodeling can be very lengthy. The patient has to have patience. The physician should have patience. Orthotics have a tremendous role. Working together with physiotherapy adds value to the ultimate outcome. Thank you all.
Thanks a lot, sir. Thanks a lot. This was indeed a very elaborate discussion of the rehab. I think it's a good take-home message saying that you need a long-term rehab and you should be patient and coordinate with the physiotherapist. Now, coming to the final talk of the day, like the lecture, Ram sir will be talking about. So, can you stop sharing your screen, sir?
I have already stopped.
Sir. Thank you, sir. So, Dr. Ram, sir is a senior consultant and practicing in Mumbai and is a past president IOA.
Can I talk? Hello.
Santosh, we lost you, Santosh.
So can you share my screen, slides? Hello.
We can hear you.
Yeah, so can I have the slide on the screen, please? Dr. Santosh, he is controlling my slides.
Santosh, can you hear us? I think we've lost Santosh.
Anyway, I can start talking meanwhile.
Yeah.
So we have heard excellent talks by Dr. Sam and Dr. C.P. Das on the possibilities of the tendons getting injured and having tendinopathies over a period of time. And we also heard that there are likelihood of different stages of tendinopathy and that we can most of the times treat them by physiotherapy or similar orthotics and manage those tendinopathies very well. And that is what almost 75 to 90% of these patients can be treated. Dr. Santosh, can I have the slides, please? Can you share the slides? So when we are talking about foot and ankle specifically, these are the main tendons that are we see them. The common are Achilles tendon, tibialis posterior, peroneal tendon, and sometimes tibialis anterior. And these are the mainly the tendons which get affected, which are the patients come to us having the degeneration of the tendon tissue. And surgery is only considered when conservative treatment fails. Next, please. And so the indication for surgery will include those patients who are sort of resistant to conservative treatment or those who have persistent pain in spite of all the physiotherapy, all the modalities of orthotics, and almost they come to us after 6 to 12 months despite the conservative treatment. That's what Dr. Sethi Das also showed you that those patients had taken 6 to 8 months of conservative management, NSAIDs, and they did not have any relief, so they came to him. And that case was excellent example of such patients who probably could go for a surgery. And there is a significant tendon degeneration or partial tears because many times this degeneration can lead to partial tears. And all of us have seen most of the time the tibialis Achilles tendon which is injured or they get ruptured in degenerative status. And this is what we have seen. In fact, I was one who was suffered because of this. I had a mid substance tear of my left calf, and that was fortunately treated conservatively because I used to go for mountaineering. I used to also do a lot of tennis, and that led to this problem. So, excessive exercises or excessive use of these tendons can lead to degeneration and partial tear, sometimes complete tear also. The functional limitation affecting daily activities, which is also one indication for the surgery. And if there are structural deformities, that is flat foot due to tibialis posterior dysfunction, also possibility of some kind of arthritis over a period of time, maybe stage 4, which may require some kind of surgeries like fusion. The bony surgery is also required. Next, please. So what are the common surgical procedures that we see? The first and foremost, which is very important, very kind of a very innocuous procedure of debridement and tendon decompression. What we mean by this is the synovectomy of tendons, especially the posterior tibial tendon, which there is a synovitis and which can be seen on ultrasound or MRI, because the X-rays are not going to show us this tendons which are swollen or some kind of fluid in the tendon shield. And those are the patients who may benefit with this kind of synovectomy. Nowadays, people are also doing arthroscopic release of this tendon. I am not used to it. I don't do the arthroscopy, but that is also given. Then so the tendon repair and reconstruction can be done. Tendon repair, especially in this case, we have shown the tendinoachilles tear, which could be insertional or mid-substance, and those will definitely require some kind of treatment. And surgical is the best way to do. Many times the athletes or degenerative tendon tears are seen, which will require surgical intervention. And then there are tendon transfers, especially those, let's say, longest transfer to PTT. And this is what also is been um, advocated in such cases, which are shown in the figure in the down right corner. Next, please. So other procedures are tenotomies, which are not commonly done, but it could be done partial tenotomies in cases of Haglund's or similar kind of degenerative problems. We don't advocate that. Rather than that, we would go in and decompress that Haglund process. And this is again can be done with a minimally invasive surgery like arthroscopic surgery, or we can do with a minimally invasive technique of excision of that fragment which can cause problems of the haggling. Then these are the gastrocnemius recession or calcaneum osteotomy when required. This calcaneum osteotomy is some kind of morbid surgery, but many times when it is required, it is very beneficial because we've seen many patients benefited with calcaneum osteotomy, getting the whole alignment change, which will help. Again, gastroscopic recession is also a common procedure in such cases. Next, please. Then Achilles tendinopathy surgery, in which there is again some kind of debridement is done, open or minimally invasive debridement, which is seen, which I can show you on this figure, which is seen. It is most of the times open. Nowadays, people also do arthroscopy. Haglund's procedure, as I've shown, the removal of Haglund's deformity is very commonly done, and it is tremendously helpful procedure, and patients feel good. The tendon augmentation for large defects are also done, and the reattachment of these tendons using the suture ankles are also in vogue. Next, please. The tibialis posterior surgery or tendinopathy surgery is again the first and foremost is the debridement of some kind of synoviectomy or synovitis which has to be tackled. The FDL tendon transfer for the stage 2 dysfunction and calcaneum osteotomy if deformity correction is required. And these are also extremely useful procedures. The fusion procedures could be done for advanced collapse or when there is a possibility of arthritis. Next, please. The peroneal tendinopathy is extremely common, especially in ankle sprains, those who are not treated well. Again, debridement and repair can be done. The groove deepening for subluxation. Now, in peroneal tendon, one specific indication that we do is a subluxation of this peroneal tendon, which can be snapped. We will see that as a snapping peroneal tendon, which requires groove deepening and fixation of that tendon with keeping the excursion free. This is very good procedure which would help the patient. And in this retinaculum repair also is needed, and there are certain different procedures which have been given. Next, please. Very important is the post-operative care. The patient, if he thinks that he becomes all right within no time after the surgery, he is wrong because he needs to be immobilized for 2 to 6 weeks, depending on the tendon, which tendon is injured. Gradual physiotherapy has to be started. Graded resistant exercises have to be started, which Dr. Sitidas spoke about. And the strengthening and the gait training is extremely important. So many times the full recovery can take almost 3 to 9 months. And the patient and the surgeon should have that patience that these patients are going to become all right, but gradual and graded physiotherapy are extremely important. Next, please. So outcomes and risk. The good pain relief in majority of the patient, and that is something which is very rewarding surgery. The risks are, of course, in any operation, infection, the nerve, the crural nerve could be irritated. The tendon re-ruptures are also possible, especially the tendoachilles, and the stiffness of ankle and foot movements, which is also very commonly seen. The success depends on the severity and adherence to rehabilitation. So again, we come back to the rehabilitation, which is very important to get the patient back on the functional normals. Next, please. So then there are certain interventions that Dr. Sitida spoke about, which are very helpful. Dr. Samuel also spoke about it. Hydrocortisone injection or PRP injections are extremely useful in some cases, but we have to be extremely careful that these injections are not given in the tendon, but they have to be in the peritendon area. That is what I've shown you in this. This is the peritendon area where the injection needle can be seen. Even this injection needle can be seen in the peritendon area. Next, please. So I would like to show you some sonographic, okay, video. Yeah, so in this, you can see that there is a snapping peroneal tendon which snaps outside the lateral malleolus, and this requires deepening of the groove and stabilizing that peroneal longus tendon. Next, please. Next, Okay, again, this is tendo-Achilles, which is infected, and there is synovitis, which we have passed already under sonography control and debrided it, and also given hydrocortisone injection. This should be given. You have to be very careful that the tendons are spared. Next, please. In this also, the tibialis posterior tendon and the sheath, we have given an injection under sonography control, and the peritendinous area, we have given this injection, which you can see, and that is the fluid around the tendon, which gives you a sign of synovitis, or it's an inflammation, it's not an infection. So this could be tackled very well with this needle. I work along with the sonographist who's expert in MSK sonography, and that is extremely helpful if you have one in your discipline. It is very specific and subjective investigation. It is dynamic investigation and very useful for our patients and orthopedic surgeons. We can also compare that along with the normal side to immediately get the, the report or find out the problem in the tendinopathy area. So one is it is dynamic, if you can compare it, and another thing is that this can be done as a rapid procedure, and patients are also, the cost of this investigation is very low. So thank you for hearing this thing. And I would like to hand this over to Dr. Santosh or Dr. Alex.
Thank you, sir. Thank you, Ram sir, for the excellent demonstration of the ultrasound video. And it's very important for all of us to know that the injections, especially the corticosteroids, if you are giving, it should be in the peritendinous area, not into the tendon. And that highlights the importance of having an ultrasound machine in your around you. Because of the PCPNDT Act, it's very difficult in an orthopedician to have a machine on his own in India. But yes, you can collaborate with a MSK radiologist and it will really help. Now, I think we'll move around with some small case discussions. We'll try to share that one or two cases. A commonest thing which we usually have in our practice. I'll just put a one slide so that we can just share some inputs and see whether we can go ahead and see how to get around with this tendons and all. Sorry, not this one. One second, sir. I'll just get that tendon case back. Okay. Oh. Yeah. So we have a case here, a 56-year-old female who came with a left heel pain and swelling since 6 months, and some of the activities of daily living are affected. But though she's 56, she squats every day to do some household work. She's from a village, and after examining the other ankle as a part of study, she says that she had a similar issue on the right and operated many years ago. Now, not much issues. So this is her clinical picture now. With this clinical picture, I would request Samuel sir, to find how do you proceed when you get this kind of a patient? What are the examination you do, and what are the investigations you want to order in the OPD basis, sir? Before we move ahead with our regular X-rays, other than the X-rays, what else you want to order, and how do you examine this patient? Samuel sir, are you there, sir?
Yes. Can you hear me now?
Yes, sir.
Okay. So I see the photos that you have put on, and it's the left foot that is involved.
Yes, sir.
So as I was trying to show in my presentation, this is an older person, and she is used to squatting that could indicate overuse or stretching, overstretching, and
Stretching.
definitely that aspect is there. Then I would obviously like to know whether she's diabetic. Many of my patients are diabetics, and that is a risk factor for tendinopathy. If this patient is a diabetic, that would really tell us why she had bilateral problems, and
Correct, sir.
which obviously on the right side did not get sorted out non-operatively, and she had to have surgery. So we would examine both legs very carefully, look at the gait to see if there is any misalignment, and from looking at the back, maybe the photo is not exactly posterior, because
Yes.
the so-called there is at least three toes that are visible, suggests if the too many toes sign is positive, but that is typically in a pronated foot, in a flat foot, which is funnily enough also a risk factor for tendoachilles tendinopathy, flat foot.
Yes, sir.
So it may be that it is an adjustment to the failed arch. It is a speculation, but in this photograph we see too many toes sign positive, and there is obviously a swelling. So the first thing I would do is to take an X-ray to see whether there is any Haglund type, bony prominence, whether there is osteoarthritis, and is there a range of movement that is clinically restricted, or it is normal range of dorsiflexion, plantar flexion, or the routine clinical tests must be done.
Yes,
And then after ascertaining whether the tendoachilles is active, is it a partial tear, for instance? It could be any of those things.
Yeah.
So you want to assess the tendon, see whether the swelling is bony in thickening, and the range of movement of the ankle, and to assess also the arch. Then I would think of taking an X-ray.
Yes, sir. Actually, yeah, she had almost a full range of motion. Walking on the toes was a little difficult because of pain at the heel, I mean, insertion of the tendoachilles. And otherwise, she is a diabetic, as you told. But the literature shows says that basically diabetes is one of the part of metabolic syndrome. Any metabolic syndromes, which includes your dyslipidemia or thyroid issues, are also prone for tendinopathies. So I think in our clinical evaluation, we should not forget to evaluate for metabolic syndromes, basically like perimenopausal age, especially in females, and the getting the thyroid profile, lipid profile, and as well as the HbA1c or the glycemic control. As you said, sir, it is very important to do that. And anyway, she was diabetic and little not very poor control, but her HbA1c was between 7 and 8. So we went ahead and she had all those tests. So we went ahead and got her X-rays done, and this was her X-ray. So the right was operated many years ago. She didn't have anything. Only with the X-ray we came to know this. So now with these X-rays, I mean, other panelist, Dr. Das sir, what would be your plan of rehab if you want to start with rehab first? Or Sam sir, will you want to do some medications first? It's a 6-month-old pain.
I just wanted to kind of mention to our participants that you also want to rule out concomitant posterior impingement. When you talk of os trigonum syndrome, posterior impingement, Haglund deformity, those things you keep in mind, because I think sometimes we don't talk about those things too much. Here you see a superior kind of bony prominence, which suggests that there has been some micro trauma there, which has bled and that has got ossified. It is not Haglund that is visible in this X-ray. It is calcification within the insertion of the tendoachilles.
Yes, sir.
So we see that very common. This is one of the commonest.
Yes, that is why I put the X-rays. Very common findings.
So there has been earlier micro trauma, bleeding, and that has got ossified. And certainly we would go through the various stages of rehab. I think Dr. Das would really take over from here.
Yes, sir. Das sir, can you put some
input? Yeah. So basically, what we discussed is fine, but you imagine every time you try to make a dorsiflexion in the left foot, you'd find this bony prominence would be digging into the tendoachilles. And if she's not, I would personally see if she's okay for surgery, and I'll go ahead and do a surgery. remove the Hegland deformity. And if not, then I would ask her to have a pair of shoe with heel range and give ultrasonic therapy and TS strengthening exercises, but by all means avoiding stretching the tendo Achilles by doing dorsiflexion, because that compression will further deteriorate the condition. So that will be my line of action.
To all the panelists, would any one of you try to inject something in this kind of a scenario? It's a common scenario in our clinical practice. If yes,
Can I say that because I'm a great believer in cortisone injection. As I mentioned in my presentation, I would do it very carefully and only once for the patient. That helps to start the patient on rehab quite comfortably, and obviously you don't inject into the tendon. You inject around the tendon. It relieves the acute pain and makes the patient go through the rehab more comfortably. So I still believe that this patient should have rehab, and many of these settle with rehab. Well, 50% of these patients who come to me, they settle with rehab, and it's a minority that I operate. As Dr. Das was saying, maybe he sees more people who come from far away and therefore they cannot participate in a proper rehab program. Then, of course, you are having to face a possibility of operating on them. But then there is this problem of post-operative therapy. So this is the play that we have. I don't know what my co-panelists will
Actually, Sam, I'm terribly scared of giving injections because the tendon, you see, in operatively, you find the tendon is significantly damaged. The slightest mistake, you are a master. In your hand, you would put the needle in the right place. So, quite often these people get pain relief and they start working more and more, and the compression increases and they come with a rupture. I think more than injecting steroid to tendon, because the moment they get comfortable and the range increases, so the deformity, the bony prominence digs into the tendo Achilles and it does further damage. So that is my understanding of the situation.
Ram sir, what do you want to do, sir? Will you inject or will you not?
Patients who generally come to me have come as a second opinion or third opinion, having practically taken physiotherapy, etc. In this, just like Dr. Samuel said, that I will give injection hydrocortisone under ultrasound control. All these injections which I give are strictly under ultrasound control, but I am fortunate that I have an ultrasound sonologist with me in the clinic. So whether it is a TA or tibialis posterior, peroneus, or whether it is shoulder, wherever I give injection, it is always ultrasound control. So I am safe, and at the same time, I have had one TA rupture in the past where I was not using ultrasound as an ultrasound tag. So I have had this unfortunate patient who had that TA rupture, who was also diabetic, controlled diabetic, about 75-year-old, but having failed all the physiotherapy and rehabilitation, he had come to me, and he had the rupture. I cannot blame the injection hydrocortisone completely, but he was degenerated. He was, when we operated him for the degeneration, we had to use suture anchor, etc. So there is a possibility, and there are incidences in the literature and in our hands also that TA rupture or the tendon ruptures are also seen. Just like any other, anywhere shoulder or even decurvence, if you give injection, there are possibilities of these tendon rupture, but you have to do it ultrasound control, so you are medically also safe. And about surgery, in this particular patient, I will do keep surgery as a last resort. But if nothing helps as a conservative, I won't hesitate to do this excision of this head length, just like in the other foot, and she will 100% get it. That I'm sure.
Thank you, sir. Thank you for the input what you have given. I think giving injection, steroid injection, you should have a good little experience, or you have to work with an experienced surgeon, especially around the TA, because a lot of ruptures are known. But as Sam sir and Prabhu sir are telling, with with a bit of caution and a very low dose, I believe. And as Sam sir says, only one injection, not repeat that. Definitely, I think repeating injection will definitely cause rupture. Yeah, so this patient, I had given a physiotherapy and she is known to one of our hospital staff. So she will come back probably if there is no improvement. So I'll just go to one more slide, which Das sir was telling. I'll just a minute. So yeah, so this is a same patient which Das sir was talking about. So can you, Das sir, can you take over from here?
I think if you put me on the screen, that will be better. Can you? Okay.
Yeah.
So this patient is 60 years, and she has bilateral medial compartment osteoarthritis of the knee joints, and she complains of both feet pain after resting for a while. I mean, part of the pain is because of the knee, and part of the pain is because of the feet. And when I saw her, I found that both the posterior tendons are swollen and they're tender, and on both sides again the peroneae are painful and tender, and so she has got on one side the arch is flexible, other side the arch is losing the flexibility. So I had done the x-rays on her, and the x-ray shows loss of arch on lateral view and wet bearing view. This is this thing. So see, I'm thinking of. I want the opinion from the panelists so regarding this. So this is the wet bearing lateral view on the right side, and then on the left side there is similar picture. And I would like to know what.
Add to this, Dr. Das, such patients having severe osteoarthritis of the knee and this problem concomitantly seen, strangely enough, which is not given in the literature, we did the TKRs and these symptoms disappeared.
Yes.
And I'm sure you must have come across these
Yes.
cases also. So I think if this patient is a candidate for TKR, we probably do TKR, wait for 3 more months and see he will be benefited.
I just wanted to tell you, Doctor, this is what I have been thinking. A lot of patients come with the foot problem, but actually because of the malalignment that develops following medial compartment osteoarthritis, these symptoms start bothering. So if you address these symptoms without addressing proximally, higher up, the alignment remains same, you probably would not give any benefit to the patient.
Yeah.
Our problem at the moment is only the knee pain is, the pain score would be about 5 out of 10, and she has medial compartment osteoarthritis. Do you think a high tibial osteotomy might work?
Do you have an X-ray of the knee?
Yes. Dr. Santosh.
So I was not advocating TKR, some kind of conservative surgery of the knee also.
I just want to share the knee X-ray. Dr. Santosh, do you have, or shall I give it?
Just to say that, when you have a medial compartment OA,
yes,
it produces varus.
Yes.
Sometimes I notice that a valgus OA knee predisposes to flat feet, and you get a concomitant tibialis posterior tendinopathy.
Yes.
So this is interesting that your patient has a medial OA and a flat feet together with that, which kind of goes slightly counter to what we would imagine. But in these patients, I think a good hip knee ankle axis
yes, the scanogram would
help us.
Yes, a scanogram probably would help. And are you able to see the knee X-ray?
Yeah, we can.
So this is not much. There is only mild medial compartment osteoarthritis on one side. Other side is again, it's okay. So a scanogram might help to look for the malalignment. But how do I approach now this patient, Sam?
Yeah, okay, you put me in the spot. So looking at this X-ray, I would be not very happy to consider total knee replacement for this patient.
Yes.
Yeah. So as I said, I would do a scanogram. We have, you have the X-ray people helping you with that, and then you know exactly what is happening.
Yes.
And in this patient, I would start treating the pronated foot with the usual things like one side you are saying it is stiff, probably it
Yes.
is gone to or going to stage 3,
Yes.
and that is a bad thing.
Yes.
Maybe one would do a good ultrasonography. If you have a good ultrasonologist, we would know what is the extent of the tendon trauma. Sometimes it is thickened and swollen because of the disarranged healing process going on there. And in that case, you may even physiotherapy may not return that leg to normality. But the flexible side, I would just consider good therapy,
Right.
exercise and all the other modalities. But the other side, I would want at least a sonogram. But many
Yes.
of our places, MRI people are more able to give us a good diagnosis.
Right.
But it depends on your sonologist.
We have both good
Okay.
ophthalmologist and MRI people, and she's moderately obese. I think the weight reduction also is quite important in this case, right?
Now,
Yes,
if
sir.
I tell my patient, go reduce your weight and come back, they don't come back.
So I think we'll go with some questions, sir. Some questions have come.
Injection
Okay.
hydrocortisone.
Santosh, the first question I have to all our eminent panelists. I recently was in Chennai for a conference, and they were talking about the magical effects of ozone therapy in tendinitis. So I think it is in Kerala, Sam. So the question comes to you.
Alex, I think what can I say? It's like this, gene therapy and all this rest of it. There's a lot of hype, and really, if you look at what does ozone therapy do, would be just that possibly that there is a little bit of oxidization that is or increase in oxygen supply, I should say, not oxidization, which may have some effect. I don't know. I'm not a believer in ozone therapy. I'm
Okay,
sorry
what
to
about
say.
Ram and that's very quick. Any
No.
I
No.
think
no, okay, I got the answer. Thank you.
So the questions asked was like, do you consider giving paracetamol or any selective COX-2 inhibitors like etoricoxib or celecoxib?
I do give NSAIDs for 8 to 10 days at least to find out the relief. I
Yes,
don't
sir.
for a long term.
Okay, sir. Okay, that should be the better.
Yeah,
I think that
I
answers
give
the question.
etoricoxib for all my patients. 1 week. One
Yeah,
week of
okay, sir.
etoricoxib.
Okay, sir. Okay.
Along
And
with physiotherapy, ultrasound, and other modalities, maybe orthotic.
yeah,
Yeah.
yes, sir.
Everything together, shotgun.
Yes. And what are the role? Why people? And one more question is why eccentric exercises are advised in rehabilitation when eccentric exercise itself is a risk factor for tendinopathy? That is the question there.
Actually, tendons heal only when they are put into some kind of stress. And the remodeling, like in the bones, if you put a LCP in a fracture and don't load it, the fracture won't heal because it's not stimulated. The
Yes, sir.
tendons get stimulated only when they are loaded. So the only factor which governs the amount of load you can give is the pain. The
Yes.
standard recommendation is 0 to 3 pain score is okay. If it is more than that, you should reduce the load. So eccentric loading is not full loading. It is reduced loading, and it trains the muscle to work and to contract and develop the strength. And the collagen 3 type 3 becomes collagen type 1 only when you are doing the loading part of it. So loading is important. You have to be careful. Eccentric loading is less than full loading. That's how.
I totally agree with you, sir, because I think it's like similar to Wolff's law, wherein bone heals only when you stimulate it. The collagen also will get laid properly only when it's stimulated. And any roles of Sam, sir, any role of adding some vitamins as well as some arginine, which is known, some of the amino acids are known to cause nitric oxide release inside the tendon, which will heal. So any of the panelists are aware of this thing, sir?
This is in I don't think there is a great deal of science, but actually when you look at some of the nutrition journals, they do talk about some effect in animals when you give them collagen, particularly for tendon. our supportive company farmed does also provide some supplements. These supplements, it's
They
very
have,
difficult to say,
yes, sir.
to tell a younger colleague, that give supplements.
I think we can use that to buy some time, sir. That is very important
No,
because,
actually,
yeah,
there is some science. Why I
yes,
said
sir.
that is in our mainstream, you go to JBGS and all that, you will not find any support for giving these supplements.
Yes,
But
sir.
when you look at nutrition journals, they do show some, there are a few RCTs. It's not that there is a great deal of, support for that. But so giving people collagen, I do
Yeah.
give for older people, because there is some evidence that there is a nutritional issue there. So I do give some collagen for these patients.
I think there is one Indian study itself, and I mean, it's happens to be of same one of our farmed companies only, wherein AIMS they have studied and they shown that it's a comparative study between diclofenac and pain relief, basically, not the tendon strength. Pain relief with nutraceuticals as well as diclofenac. They found out that you cannot give diclofenac for a long time, no, sir. In our studies, I mean, a lot of other factors, but they found out the pain was significantly reduced after many days, many weeks of therapy. But I also feel that the rehab we cannot, take the seat backwards for rehab. Rehab is the most essential, and sometimes patients keep on demanding something from you. At that time, I think these supplements will help them to overcome the metabolic deficiencies what they have. That's what I feel. Not directly helping in the rehabilitation or repairing the tendon, but they definitely help in reducing the deficiency syndromes what the patients, most of our Indians have.
So absolutely right, Dr. Santosh and Dr. Samuel, that nitric oxide has lots to do with inflammation. Okay, and we have to, all these nutraceuticals are definitely better than placebos for sure. They don't act just like a placebo as some people think. And even our Ayurveda and ancient literature also show turmeric and those Boswellia serrata and all these factors are very important as anti-inflammatory. And they have been shown in scientific studies and in lots of research labs too.
Yes, sir. I think now the questions are also over. I'm giving it to Dr. Alex sir to conclude, I believe now.
Yeah. Thank you, Santosh, and thank you, Das and Ram Prabhu and Sam. I think it was a very interesting discussion, and I think a holistic discussion, because generally we allopathic guys don't look at anything else. We think only of allopathy. But yes, I think from your experience, I think we have looked at the whole gamut. So thank you once again, and thank you to the audience also. Thank you to FarmEd. Our next webinar will probably be on, again, we get feedback from the participants. And this video will also be circulated. I think more of the video circulated is being seen by others as through the FarmEd company. And the next one, we are looking at wrist and hand, probably in about 6 weeks to 2 months. And then after that, we're looking at unusual tendinopathy. So we'll keep you posted. But thank you so very much. And it was a very interesting discussion. I found it interesting. I think the audience also did. Saurav, you want to add anything before we close? Thank you.
Let me also
Yeah.
thank the sponsor, Dr. Alex, Dr. Santosh, CP Das and Samuel, and FarmEd, of course, for getting us together with so many participants. It has been a great pleasure and honor to be on this webinar.
Thank you, Ram. I think it's our privilege to have three very eminent professors.
Alex,
Dr. Alex, thank you for the opportunity. All the doctors, thank you for the opportunity. We always look forward for such sessions. The case discussions were great. And I'm sure that we have recorded the session. There are a lot of requests which we got for the recorded session. And Dr. Alex and others, Dr. Ram Prabhu, Dr. Das, and Dr. Santosh, thank you for being a great moderator for us. We will continue to do such sessions which will take forward science, which will take forward the evidence, and the younger orthopedic doctors get a lot of insights from these things, Doctor. Thanks a lot. Thanks all the participants.
thank you.
Thank you.
People logged in.
Thank you.
There were around 140 at a time, sir.
Bye-bye.
Bye.
Yes, sir.
Right.
I think it
And
was YouTube live also. So it was there on
absolutely.
that. Yes, sir.
Thank you.
Yes, sir.
We'll
Thank you,
share all
sir.
the statistics. Thank you, doctor.
Yes, sir.
Thank you.
Thank you, sir. Thanks a lot.
Thank you.
Thank you.
Nice to meet you.
Nice.
Thank you, Dr. Santosh.